And then now we move to the third topic. Welcome, Dr. Hembroth.
Yes, somebody's sharing their slide. Okay.
Yeah, I quit.
Okay, thank you for your invitation to be here in this webinar. And please let me tell you that any question that the audience might have, you can just send it to me because I'm reading the chat, but I don't know if I see that not the whole audience is in this chat. So maybe Michelle, you can take the questions to us. So my talk is it's very specific because I'm very obsessed with details. So instead of bringing many cases, I will go a little bit deeper in just one case. So this is a complex case. This is the use of BrosMed pod balloon in severely calcified and bifurcated lesion prepared with rototripsy, which is the combination of rotoablator and lithotripsy. I'm Pablo Salinas from Hospital Clínico San Carlos in Madrid. And I maybe skip these technical slides, but being very straightforward, what we need when we want a non-compliant balloon is just to be strong and avoid rupture, to stay within the markers, and to be able to fold it again to be used and reused. So if you see this picture, you will feel instantly attracted to this balloon, because you can see that even at high pressure, it's very slightly going beyond the edge, and it really fits the bench testing, which is sometimes something that it really doesn't happen. These are the technical specifications. I just wanted to point out that every balloon is going across a 5 French catheter, but only the biggest balloons will need a 6 French, but I don't think this is a strong problem because we are most of the operators working on 6 French. But in case you need to treat a large RCA, for example, 4.5, 5.0 balloon, just remember that it won't cross across a 5 French guiding catheter, and the other technical aspects are just standard. It can stand up to 24 atmospheres, but I have inflated this balloon up to 26, 28 without problems. So this is the clinical case. This is a 71-year-old male with unstable angina, normal echocardiogram, and 3-vessel disease. We assess a syntax 2 scoring, and he had equipoise between PCI and CABG. We started doing rotablation and 2 drug-eluting stents, and LED is won't be shown here. And I scheduled the second procedure for the RCA treatment. This is the right coronary artery. You can see it's a very complex vessel with a lot of calcification and very diffusely diseased with some ectatic areas. There are 2 areas of major calcification, the proximal part and at the distal part near to the bifurcation. The patient was obese, so maybe the angiograms are not so perfect. We approached the case with a left radial 7 French AL1 guiding catheter. We decided to do upfront rotablator to have good crossing options for the balloon treatment afterwards. So we picked a floppy rotawire and 1.5 millimeter bore. And this is the rotablation with the 3 runs at 170 and 1 slower run at 140 to have some more opening. We didn't cross up to the distal PDA because I'm not showing it here, but it was uncrossable by the microcatheter, so we have to navigate the rotawire down the vessel, and it was not far enough into the PDA, maybe if we wanted to cross the bar to the PDA, we had some risk of getting to the right part. So this was the aspect of the artery after the rotablation, and we decided we needed to assess it with imaging. So we did OCT. This is ultrasound system. You can see in the orange ring is represented the calcium arc. So you can see it's almost 360 degrees arc. And also there is the dimness of the calcium. So here we had 0.8 millimeters of calcium plaques. So that would be a lot for a regular balloon. So we decided to do pod. The most calcified part was at the most distal part, very near the bifurcation. And in the proximal part, there was also a lot of calcium with a bigger lumen. So we tried to get the shockwave balloon across the bifurcation, but we couldn't cross it even after 2.5 millimeter pre-dilatation. The shockwave did not cross. We had very good support with the AL7 French wire and high support wires, but it didn't cross. So we treated where we could. This was just the distal part, 60 pulses and 20 pulses in the proximal part with the same balloon. And this was, sorry, this was the angiogram after the shockwave treatment. Okay, you can see some luminal gain. You can see patency of the posterolateral branch. So we decided to open it a little bit, the bifurcation. We were not happy with the shockwave not crossing the bifurcation. So we started the trying to get down the vessel a Wolverine. This is a cutting balloon. This is 3.0 Wolverine at standard pressure. Didn't dilate, and then we raised to 18 atmospheres, and it opened up the bifurcation here. This is a more proximal position, but it did open the bifurcation. So then we took a stent, and we decided to go provisional on this bifurcation because we had good patency of the posterolateral, and it's simple. And if you take the European bifurcation consensus on bifurcation, you can read a summary here of one of the tables, and one stent strategy is recommended for the vast majority of bifurcation lesions. I would say 90% of the cases. And you have to pick up a stent selected 1-1 according to distal main vessel size, and this is followed by systematic pod. So there is always step up in size from the distal vessel to the proximal vessel, and that is handled with 1-to-1 stent size into the distal vessel followed by pod. So this is mandatory. And when side branch intervention is required, there's the option of pod side pod, but I think there is a consensus on using kissing balloon rather than pod side pod if possible. So then there's a final pod after the kissing balloon. Again, this is called repeat pod or repod. If you are doing pod side pod, there is the repod again. So you need a balloon that can do pod very precisely, and which is also amenable for a second reuse for the repod. And then you have to pick up your stent platform, and not every stent platform is the same. We have this nice research paper where they overdilate regular stents and show which was the maximal stent dilation capacity. For this case, we pick up a superflex screw stent because it has one of the most wide options for overexpansion. It reaches 4.25. You can see it here in a different case. This is inverted provisional stenting from LAD to diagonal, which was a dual system, and it was larger than the LAD actually, with no disease in the ostial LAD. And we got a 2.5 stent here, and we post-dilated with a 4.5 balloon. Sorry. And if you can see, the IVUS here, you have 2.5 in diameter and over 4.0. So this is very nice. This is pod, but not every stent platform will reach this diameter. So please know the limits of your stent platforms. Coming back to our case, this is the BrosMed 3.5 and 8 balloon at 14 atmospheres. And I want you to check where the balloon is positioned. And when we are very precise, you can use also stent enhancement tools, as was shown before. you have to get the balloon just at the bifurcation. And you can be very precise with the marker positioning, but if the balloon will go beyond the shoulders, all this precision will be spoiled. And if I can show you this cartoon now, these are incorrect positions. This balloon is too distal, so it will shift the carina, which is something very difficult to correct. You will have to do kissing balloons here and then repot to correct this carina shift. This is what the most frequent cause for side branch occlusion, and also you will overstretch the distal main vessel here. So this is a too distal position, and on the right you have a too proximal position. This balloon for pot is positioned too proximal, and you will have an incomplete expansion at the side branch ostium. This is non-favorable deformation of the stent side cell for rewiring and dilatation. So even if you want to do kissing here, you will probably go through a very proximal cell and you will have a neocarina here. So if you happen to do a too proximal pot, the way to correct this is send another pot balloon here and pick up a more correct position. Okay, so if you do a too distal position, correction is kissing balloon. If you do a too proximal pot, correction is repeating the pot at an optimal position. And which is the optimal position? The optimal position is here. You can see the correct position of the balloon, and you can see that you are deflecting the opening of the stent towards the side branch. So you will recross over a distal position, and you will also have more coverage, stent coverage of the side opposite to the carina where most of the plaque will be. And coming back to our case, we had this position of the balloon, but as I said before, not all balloons are created equal. So it's very easy if I show you this couple of images. This is just the case. This was a left main bifurcation that I treated in a referral hospital, where we also do catheterization, and I didn't have the BrosMed balloon. So this is a competitor, and you can see this is a 4.5 at probably nominal pressure, and it's going way beyond the marker. It's almost 5 or 6 millimeters beyond the marker. So this is the plain difference here with the BrosMed POT balloon and a regular balloon. It's not very difficult to be much attracted to the right image here. So after doing the correct pot, we also dilated the proximal part of the stent to have a 3.5 diameter and be able to overlap the next stent. This is the angiogram after stenting of the distal bifurcation and pot. You can see very precisely how this stent is smaller in the PDA and it's bigger in the proximal part. So it's 275 here and 3.5 here. This is not me guessing, this was the OCT. And then you have to decide if you pull back this wire or leave it here. So we saw some stenosis at the ostium, and we decided to keep it here and see what happened after opening the most proximal part. We continued the case. So we overlapped another joint stent, 3.5 and 28 in length. And the surprise here was that the area without obvious calcification was underexpanded, even that inflating this stent at 16 atmospheres, it didn't dilate. So we took the same balloon that we used. This was the third or fourth dilatation with the same balloon, and you can see very nicely that it still stays within the markers. So shoulders are as designed, very small, not over 3 millimeters, and this is after using and reusing the same balloon. This was 20 atmospheres, the stent opened up, and this was the angiography here. So we decided the distal part of the vessel was satisfactorily treated, so we pulled back the jail wire and we focus on the proximal part. This was a 4.0 millimeter drug-eluting stent at the proximal part, and we got an edge dissection. You can see it here. It's angiographically seen, and it's also very easy to see in the OCT, very beautiful image of medial dissection here. This needs to be treated, and we use a new BrosMed PRT 4.5 an H balloon. This was an ectatic part of the vessel. And again, you want to be very precise to avoid edge dissections. This could be a random competitor microscopy image of the balloon with the shoulders. You can see that regular shoulders are 3.2 in this balloon, so that would make 6 in both ends. And you can have two kind of mistakes using these balloons. You can either be too distal with the balloon, and then you risk damaging the adjacent non-treated vessels with the shoulders. And also, if you put the balloon too much inside the stent, what you will have is this called bottleneck effect, where you will round the edge of the stent, making it very hard to cross if this is happening in the proximal part. So if you want to be very precise and get to the stent and protect the healthy or non-healthy but non-treated area close or next to the stent edge, you will probably pick the balloon with the shortest shoulders. So this will be a 0.6 millimeter shoulder. Theoretically, I think in reality it might get to 1 millimeter, but 1 millimeter and 1 millimeter is just 2 millimeters. Is probably below your actual precision when positioning the balloon. So this is more than fine. I think it's without any doubt the best balloon available in terms of precision when positioning and dilating stent edge. So this was the final result. In the left, you can still see some contrast going behind the stent struts into the dissection plane, which was huge, but in OCT, the whole dissection was covered, and you can see also the distal part that was satisfactorily treated. Is obviously not the best results in terms of diffuse disease, proximal and distal to the stented segments, but I think that the vessel improved a lot from the beginning of the treatment. And also sometimes you have to decide where to treat, where not to treat, because otherwise you will have a full metal jacket, and it was not a good option for this patient. And there's also some areas here with aneurysmal parts where you won't get stand-up position, and there is a safety concerns on stent thrombosis if you will put a stent on these areas and there is not real stenosis here. Maybe we could have overlapped a smaller stent here, but we thought this was less than 40% stenosis, and we left it as it was. And you can see also the bifurcation with TIMI3 flow into the posterolateral. So we left this as it is, and this is highlighting the OCT result in the bifurcation. You can see 1:1 sizing from the stent to the vessel size, 275 in the distal part. You can see here at the horrible circular calcification how the BrosMed balloon was able, and of course the shockwave preparation, open up the distal part of the stent, and this is the more proximal, reaching 3.5, and good MSA across the stent. So these are my take-home messages. The BrosMed POT PTCA balloon makes results predictable, and I want to be predictable when I get into cath lab. Bifurcation lesions are present in more than 25% of PCIs, and provisional stenting works in, I would say, 90% of cases. POT is mandatory in a provisional study, and I showed you before. I hope that POT is all about precision. So BrosMed POT balloon is my balloon of choice for precision PCI, and I think it's the best one for POT. And again, in other scenarios, such as calcification, BrosMed port PCA balloon is also a very precise balloon, and it's very safe when post-dilating stent edges to avoid edge dissection. It has the shortest shoulders. As you can see in the picture, it's almost a square shape in the balloon, and it stays within stent size even at highest pressure against severely calcified disease, as I showed you in this case. Thank you very much. I will take your questions now.
Thank you, Pablo. Thank you very much for your teaching us also in the correct bifurcation treatment complement to use this balloon. I have just a small question for you. Despite the name pot balloon, so we can use this balloon in the performing of pot technique, I appreciate in your presentation, your case treatment, the use of pot balloon also in the phase of pre-dilatation or normal post-dilatation. So what do you think the need of this balloon? Just dedicated to pot dilatation, or you can use this balloon also to normal post-dilatation of the stent in our clinical practice?
Well, a balloon is a balloon, so whatever use you want to put to the balloon, it will respond. My point with the case was that sometimes you have very technical specifications that works with the first inflation. For example, you have very good crossing profile, but then you do one inflation and that crossing profile just goes away. But actually, you can see that I had a clearly under-expanded stent, and this balloon worked very, very well, and it was like probably the fourth or fifth inflation with the balloon. So I think in reality, the balloon works very, very nice, and I don't see any reason not to use it. If I can show you again this picture, this is just if I can share you again my presentation. Can I share again my screen, Michelle? Let me extend 1 minute. Michelle, can I share my screen?
Oh, yes.
So two reasons to pick up this balloon. One reason is this one. So this is very simple. You have two balloons. They're all the same price. Which one do you prefer? So it's very easy. This one is more square, is more precise. It won't go beyond the markers. And this was the first use of this balloon. It was not like the fifth. It was the first use, and it's clearly going beyond the edge. And another thing that is not what I was planning to talk about, but I brought this presentation because I think we all read this interesting paper where we saw that pot actually elongates the stents. It doesn't shorten the stent, but it elongates. This is a very nice paper recently published in Urointervention. So the reason beyond expanding the length of the stent with pot, it's obviously when you use very large size balloons in maybe mid-size stents. This is a 3.0 stent reaching 5.5, and it's extending for 4 millimeters. This is very extreme, but the mechanism behind that, it's probably that the shoulders are getting into the most distal part of the stent, and it's pushing the stent behind. If you see the cartoon on the right, the mechanism behind this is that the shoulders are pushing the balloon more proximal. So maybe, and this is just guessing, but maybe this longitudinal deformation has something to do with the shoulders. So I just want to point out that well, if you have a balloon that it's just a little bit with this small detail, but if it has shorter shoulders, why would you pick some different balloon that has longer shoulders? There's no reason to pick a worse balloon, right?
Great.
Dr. Salinas, these tests you performed with pot and stent elongation were performed on a stiff model or elastic model?
This is not my testing. This is a recent publication in your intervention, and it is a bench testing. Okay, so they use like
There
5 or 6 stent platforms, and in a bench testing they over dilated the stent up to 5.5, and I mean, intuitively, I thought that when doing radial expansion, the stent will shorten, but actually they showed very beautifully that the stent elongates. So I invite you to check the publication, but actually it's a bench testing. There's no in vivo demonstration of this, but I have seen sometimes this kind of behavior, especially in osteums. Sometimes I have seen this when over-dilating, when doing the stent flare. If you measure your stent length after, and I've done this in a couple of cases with CT, you can actually see that the stent do elongate. So I really believe this is true. The question is, why is it happening? And one proposed mechanism is the stent shoulders. So maybe we should ask the authors to repeat the testing with the POT balloon.
Okay.
Okay, thank you so